I'd like to introduce Dr. Ramona Dadu. She's an endocrinologist from the University of Texas MD Anderson Cancer Center here in Houston. Dr. Dadu is an assistant professor in the Department of Endocrine Neoplasia and Hormonal Disorders, Division of Internal Medicine. She received her MD at her university in Romania, where she also trained in clinical pharmacology and toxicology. After graduation from an internal medicine residency in Connecticut, she joined the Baylor College of Medicine MD Anderson Center Endocrinology Fellowship Program and entered the Clinical Scientist Training Program, where she received extensive training in grant writing, conduct of research, and biostatistics. Dr. Dadu is the principal investigator in research titled Immune Markers in Medullary Thyroid Cancer and Their Clinical Significance. She is the author of several peer-reviewed publications related to thyroid cancer and was awarded the Women in Endocrinology Young Investigator Award in 2014. Dr. Dadu.
Thank you all for being here. If you don't had the opportunity to meet with me in clinic, I am for sure reassuring you that a lot of your cases have been brought to my attention, or throughout the many years I have been participating in caring for a lot of the cases at MD Anderson. I was asked to speak about management of anaplastic thyroid cancer, and I know that Dr. Cabanillas is going to give a pretty extensive overview on the topic tomorrow as well. So instead of giving a duplicate on the same subject, we have very similar opinions of how we should be treating this disease. I thought that maybe we'll take this opportunity to bring it up to more, where are we going from here? What are you all interested in us doing for the future trials? And kind of learning from you all of where this field should be moving forward. I think all of this is a partnership between us, the investigators, but also you have gone through a tremendous time frame in terms of learning along with us. So we truly appreciate your help and your partnership with us to get where we are today. I know a lot of familiar faces in this room because they are my colleagues. So I would like to just pass the microphone to everyone to kind of just introduce yourself and kind of just bring up to my attention, of our attention, what would be the most important one or two things that you would like us to continue to work on, or what are the challenges each of you is facing, and how we should move the field forward.
We're going to start in the back of the room.
Yeah, that's perfect.
Yay. Okay, my name is Nikki, and I had papillary cancer 10 years ago, and then something somewhere mutated, and now I have anaplastic. It's been just about a year and a half. I am BRAF negative and RAS positive. So I would love to see some science in that direction, because I know that haven't quite gotten there yet. So I'd love to see the science go on the BRAF negative, BRAF negative, RAS positive side. I guess I don't know what else.
And where are you being treated?
Dana-Farber in
Okay.
Boston.
I'm Max Nicholas from Southern Indiana. I've been treating at MD Anderson. Had anaplastic thyroid cancer, diagnosed 7.5 years ago. So far, it's been NED for 7 years. Doing well. Still work, do everything that and I really don't have any questions. I'm just here to see if I can learn anything. Okay.
Yeah. You are teaching us, Mr. Nicholas.
Trust me, my wife asked any questions that I've heard. Okay.
Would you like to say anything?
No.
No.
Hi, my name is Larry. I was diagnosed beginning of June, being treated at Memorial Sloan Kettering. I'm really just here to learn and to see, what people are doing and how things are affecting them. I've only been diagnosed for like 3.5 months.
Welcome.
My name's Paula Behrens. I'm from Michigan. I first had papillary cancer in 2019. It might have been 2018. I don't remember. And so I had a surgery, took out my entire thyroid. And I was always told that 97% chance of getting over papillary. So I didn't even think about it. And then 17 months later, I had a surgery because I thought there was more lump. And they found it anaplastic encapsulated. And the surgeon said, "Oh, don't worry about it. It's encapsulated." Well, 3 more months, and that was really the time to worry. Another surgery. There were 4 out of 8 lymph nodes were anaplastic. And they took that out in 3 muscles. But they never did say why they did that. I imagine there was things there they didn't want to tell me. But I've been doing great since then. This past June, it was 4 years since they've seen anaplastic.
That's great.
I just met Dr. Dadu yesterday, so that's why I'm sitting in today. But
Welcome.
thank you. I'm from New York, and I'm 4 years, and I have poorly differentiated.
Hi, I'm Julie Martwick. I'm from a small little island in Seattle, Washington, and I was diagnosed with poorly differentiated 4 years ago.
Would any of these nurses like to?
Yes, please introduce yourself. This is my entire team here.
Hi, my name is Ann Brinkman. I'm one of the nurse practitioners at MD Anderson. And I guess one thing I would like to know is how we can predict better which patients with papillary or something else might transform to anaplastic later.
I'm an exhibitor.
My name is Amori Salami Henry. I've been at MD Anderson for 9 years. In August will be 10 years. Been working with Dr. Dadu for that length of time. I mean, she, just as you see Dr. Dadu, that's how I've known her 9 years ago. I mean,
Thank
she's
you.
very approachable. I mean, she loves her patients are not even her patients. They're like extension of her family members. And I learn a lot from her every day, even though I've been there, and she learns every day. We learn from you guys every day. And we just want to thank you guys for just entrusting your health, your health in our hands. And because of you, that's what we're learning. And so I always learn every time doing our weekly, let me give the mic away. Here you go. Okay.
My name's Sue. I'm also a nurse practitioner, work at MD Anderson, and actually I started working with the Dr. Dadu when I joined the endocrine department. But then now I actually work with another provider, and also I work at Thyroid Cancer Survivors clinic side. So I do have a good side of the cancer survivors as well.
Hi, my name is Blair Goldstone. I live in Atlanta, Georgia. Got diagnosed with anaplastic a year and a half ago, and I am at MD Anderson. See Dr. Busaidi. Would like to know more about being BRAF negative and what treatment options are out there for me. Currently, I'm NED, no evidence detected, and I want to keep it that way for a long time.
Yes, that's the goal.
Hi, I'm Patty Turner. I'm from Dawson Creek, British Columbia, Canada, way up there.
Cheers.
I was I was diagnosed with anaplastic in September of 2011. And I had radioactive iodine and radiation and 2 surgeries. And I'm good now. My worry is that it might come back one day, and also dealing with side effects from radiation and radioactive iodine. My swallowing's going, and I wonder how much longer I can keep swallowing normal.
Hello,
Hi.
I'm Stacy. I was originally diagnosed with thyroid cancer in 1991. It came back 31 years later in a lymph node. I had the whole thyroid removed in 91, and it mutated to anaplastic thyroid cancer. And it was mixed with cribiform morel, if I'm saying that
Oh,
right.
Lord.
So I have no mutations, no BRAF or RAS. So curious about what's out there for us with no mutations.
I'm Leslie Mellinger. I was diagnosed with anaplastic thyroid cancer in 2021. Dr. Sperry and Dr. Cabanillas on my team. I've been no evidence of disease for 3 years.
Wonderful.
And I'm like you, I no mutations, BRAF negative, weird duck out here on the side. And I did 2 years of Keytruda as well. But what is there to keep it from coming back?
You're with her. Okay.
Hi, my name is Sarah Hamidi. I'm an oncologic endocrinology fellow right now at MD Anderson, and hopefully I'm gonna join faculty at MD Anderson in January as part of the team with Dr. Dadu. And one of my main interests is treating anaplastic thyroid cancer. So hopefully I'll be seeing more of you guys, but very interested in doing a lot of research in what more we can do for ATC patients.
All the question was what's coming. Direct them to Dr. Hamidi here.
Hi, my name is Christina Bowie. I'm not sitting with my friends because I came in late. I'm one of the nurse practitioners at MD Anderson Cancer Center. I count at least 4 of my patients in the audience. So hello, all of you. So nice to see you guys outside of clinic. And I work hand in hand with Dr. Cabanillas for the last 5 years. So technically they are her patients, but I consider them my patients too. So, because I don't plan on going anywhere. I love our patient population. I love our patients. I will be so sad when Dr. Cabanillas retires and I have to work with somebody else.
Not retiring.
No offense. Well, she talks about it sometimes. Well, someday. I'm just saying someday. It will be a sad day for all of us because she's terrific. But the other providers are terrific too. But I'm biased because I work with her, hand in hand. But anyways, that's enough about me.
And Christina has made these wonderful pins for all of us celebrating ATC survivors today. So that's why we are wearing them. So thank you, Christina, for taking the time to make so many pins. Great. We have a lot of people on Zoom. I don't think we have time to open the microphone to introduce everybody here. But if you have any questions, please place them in the chat. If you want to participate, raise your hand and we will give you the microphone on Zoom as well. So what I hear in the room, it seems like it's a mix of new diagnoses, a lot of what we call long-term survivors for anaplastic thyroid cancer. And I'm really so happy and hopeful that things are going to continue to move forward in an even better outcome for everybody with anaplastic thyroid cancer. The other thing I've heard everybody talking was the first thing that they mentioned, I have anaplastic and I have this mutation, or I don't have any mutation. So I think the education did go up out there, extremely important to interrogate the tumor for the mutational alterations or other genetic alterations of the tumor. So you are all so educated just by hearing you talking and saying the first thing you say is what kind of mutation you have. That's exceptional. So great work in educating yourself with what's coming. And you all also said something also extremely important. We have spent the last almost 10 years working on BRAF mutated anaplastic thyroid cancer. And back in 2013 is when we start having drugs that could target the BRAF mutation. We had drugs approved for anaplastic thyroid cancer with the BRAF mutation. So we did focus quite a bit, a lot of energy on that particular group, which is less than 50% of anaplastic thyroid cancer patients. And this is where we see the most successful outcomes. The testament here in the back row right there, a survivor of 7 years has never been even a dream for us 10 years ago. So it's great. And this is exactly where we are going next. We actually going to have an anaplastic thyroid cancer retreat here in Houston in a couple of months, discussing specifically where the field is going to be going in the non-BRAF mutated anaplastic thyroid cancer. So I will want to assure you that there is a whole lot of work being done in collaboration, not only at MD Anderson, but across the world to now focus a whole lot of our efforts in the non-BRAF mutated anaplastic thyroid cancer. But also a second priority is what do we do past the 5-year marks for survivors of the BRAF mutated anaplastic thyroid cancer group? We know we can get to the 5-year mark. We know that with very aggressive upfront approaches, surgery, neoadjuvant treatment, immunotherapy, chemoradiation, all of those upfront aggressive treatments are paying off. But also I've heard from some of you all talking about the long-term consequences of those aggressive treatments we are proposing upfront for BRAF mutated anaplastic thyroid cancer. So we do have more and more survivals after the 5-year mark, but in my experience, I do have now more and more patients presenting with the long-term consequences of radiation or surgery with radiation and so forth, strictures in the neck, strictures in the trachea and esophagus, inability to breathe or swallow because of the scarring from such aggressive treatments. And then another priority really would be to understand, and hopefully Sue right here is going to help us in that, when are we going to call an ATC cured? And when are we going to call them a survivor of anaplastic thyroid cancer? We cannot even, when I started doing anaplastic thyroid cancer 10 or 11 years ago, I have never used the word cure in my practice. And many of my patients know that. But I'm here trying to be brave and and trying to see what is an ATC survivor? When are we going to say we do have a survivor of anaplastic thyroid cancer, and now is maybe the timing to be less aggressive in how we treat? What is that mark? So the next approach will be, and Dr. Hamidi here is going to help us answer some of those questions, is should we stop treatment after 5 years? Should we even dare to say you have no evidence of disease at 5 years? Can we stop the treatment and see what happens? Are we harming more past a certain time frame rather than having additional benefit past a certain time point, which we don't know what it is? So a lot of the research that has been done in the past few years is really to understand how to predict who's going to recur, how to predict or find a good biomarker that we can follow in the blood for us to follow up and predict who's going to have their cancer returning. And again, Dr. Hamidi here, along with our group, has worked quite a bit in detecting a biomarker test in the blood. It's called Signatera, looking at a mutational analysis in the tumor to see how that correlates with scans. So for example, they will take the tumor, they will look at a certain genetic profile of the tumor, and they will prepare a personalized test for each patient based on their own tumors. And predicting and measuring that in a serial fashion, we could say, okay, if your tumor marker or circulating genetics in the blood remains 0 for so long, you have no evidence of disease, maybe you are cured and maybe we can stop the treatment and then continue to follow those measurements of that biomarker in the blood at certain intervals to know if the disease is coming back even before the scans are going to show it. So having that additional level of security that we are doing the right thing by now drawing back in terms of treatment options. In terms of RAS mutated tumor, those are quite challenging. We learn every day. There are more and more now clinical trials trying to target some of the RAS mutations. There has not been a successful direct RAS inhibitor, but other ways to treat that are underway. And I think Dr. Cabanillas is going to explain the clinical trials that are coming up tomorrow. Very few patients with anaplastic thyroid cancer actually do not have a driver. So if you have a form of poorly differentiated or anaplastic thyroid cancer where a driver is not found, that maybe it's a good idea to double check with a different platform and make sure that all of the due diligence has been done to really go for and finding that driver. The most common drivers are the BRAF, RAS, and several fusions. So each technology is different in terms of how we find those abnormalities. So if one technology didn't find it, maybe another one will. So be your own advocate to try to understand what exactly that driver of the thyroid cancer is, because this is really what is going to make a huge difference in treating your cancer. And then apart from just targeting the mutation, really in anaplastic thyroid cancer, the immune system comes into play quite a bit. We have done many studies looking at the immune environment of the anaplastic thyroid cancer tumors, and it's very clear that it has a really important it's a very important contributor to cancer progression. So targeting that immune system is by far extremely important. How and when to use the immunotherapy for treatment of anaplastic thyroid cancer has been a subject of a whole lot of debates. In our practice at MD Anderson, we do advocate for upfront therapy with immunotherapy along with targeted therapy. I know that some other centers may not follow the same approach, but we are strong believers that the earliest we can introduce immunotherapy, the better the outcome is. Again, Dr. Hamidi here has helped us publish our experience showing that really when you combine the targeted therapy with immunotherapy, the survival is much improved. So that's where I think there is a little bit of difference of how we think about treatment up front, but always ask about the option of how can I receive immunotherapy along with other drugs. That's exceptionally important. And I'm going to stop here, just like to kind of answer any other questions some of you might have.
I'm curious what your thoughts are with the CAR T cell therapy. You've not mentioned that yet.
Yes, but we have a speaker coming to talk about it. We are learning. We are in the process of getting that started and running. We do have a clinical trial right now at MD Anderson looking at CAR T in anaplastic and poorly differentiated thyroid cancer. Those are particular CAR T that target ICAM1. It's an Affimmune study sponsored by the company. We have had maybe less than 5 patients. How many patients treated? 9 or 10 already. Okay. We are still learning in terms of, we meet now every 2 weeks to learn from every single patient experience. And these CAR-T patients are the one that we are reviewing first. We have probably reviewed most of them right now. It's a lot of learning. I cannot predict at this point if and when it's going to be on up and running in anaplastic thyroid cancer. This is a cohort study in a bigger study, but we are hoping to move it forward with a very specific inclusion criteria that makes sense in terms of efficacy. Right now, it's open to almost everyone, and the patients who go on the trial probably is a little bit too late because we have to exhaust all our treatment options, and then we send them to the CAR-T trial, and I think it's probably too late when we do that. So we are learning on how to better find the patients and send them to the trial when it's the best timing for them. Just to give you an idea, the CAR-T trial, what they do, they they take the entire immune system, the lymphocytes, and they engineer in the lab against that particular ICAM1 ICAM1 protein in the thyroid cancer cells, and then they engineer that in the blood and then infuse it back to the patient. And I actually just have a patient who's going through it right now. It takes about 6 to 7 weeks for the company to make the CAR-T. So after they take the cells out, we have this 6 weeks period waiting and doing almost nothing. For anaplastic, that's an eternity, right? It's like too long, and the process cannot be sped up. This is how long it takes. So the patients who are already progressing, maybe not the best ones to go on these kind of trials, because by the time the CAR-Ts are made and ready to be infused, the disease is taking over too quickly and may not be the right timing, but maybe early on, I don't know, maybe taking the CAR-Ts and engineering it early on when there is no evidence of disease and infusing it immediately when you see something coming back, something on those lines. We don't have a definitive answer. I would say that most likely the patient population who is going to respond to CAR-T is going to be the low disease burden and more slowly progressors, rather than allowing this to progress and then too far out from the diagnosis, maybe not the right option. So that's up and coming, and Dr. Samer Sroor is coming on Sunday, I believe, to talk about the specifics of this trial. So go and attend. He's going to explain everything that's being done for that trial and how they are doing it. But that's part of our future development as well. Excellent question.
My question is, what, like, will you like, okay, I had it formed in my head and then, so for me, I was curious if there'll be, or if you'll be looking into like how thyroglobulin, works as like a marker. Like for myself, when I had papillary post, RAI and all those kinds of things, for 10 years, my thyroglobulin never went below or down to a 0. It always stayed in some form of a double-digit number, but it was never anything. That's all it was just traceable, but never became anything until a decade later, it became anaplastic. So I was curious if there'll be, and I know that there's someone else presenting on that too, so I'm going to go to that too. But I just didn't know if that was going to be, or if that is one of the markers you guys will be looking at.
Yes, thyroglobulin tends to be a very poor marker for poorly differentiated anaplastic thyroid cancer. So we do not rely on measurement of thyroglobulin levels in pure anaplastic thyroid cancer. when there is a transformation from papillary or from follicular, or if there is a mixed component of papillary or follicular, you may see that there is still thyroglobulin production. In most of patients who have just anaplastic, the thyroglobulin is extremely low and it doesn't change over time. But where is a mix of papillary with anaplastic, when you see a transformation, we may see the levels fluctuating. Really, the goal is to treat the anaplastic, and the papillary component of it doesn't really, is not of as much of an importance at that point anymore, because your goal is to go after the anaplastic rather than going after the leftover small papillary. So I don't use thyroglobulins when I follow anaplastic thyroid cancer patients. I use it in a very specific context, and I think is very helpful, where you know that there is anaplastic in the neck that has progressed from a papillary, and then somebody may have lung nodules or liver mets, and you don't know, and they're so small, they're slowly growing. And I do have many patients where we believe that the lung nodules are actually papillary and they're not anaplastic form. And you can see how the thyroglobulin may change or rise over time, and the lung nodules are very small and slowly growing over time. So that clinical pictures along with rising thyroglobulin levels give me a lot of reassurance in that setting, because I know wherever has spread to the lung now, it's not the anaplastic form, but more of the papillary form, and we may treat that a little bit differently. So in that scenario, thyroglobulin level is a great marker just to give us reassurance. We cannot biopsy those lung nodules, they're too small, but the fact that thyroglobulin is rising could be a positive thing in that setting.
I need this at work. You clipped my mom voice and my teacher voice, so I need this at work. My lung nodules, I did get biopsied, but unfortunately for me, mine turned out to be ATC positive. So that sort of sucked for me, but
Yeah, so sorry to hear.
it was better than the psychological push off the cliff when he said, well, it could be 3 different kinds. And I was like, oh, that hadn't crossed my mind. So that was different.
Yeah.
This is David Schuck. I'm on virtually.
Yes.
I had a question about your discussion of the CAR T cell trial. Were you saying that it's not available to patients who are currently being treated, such as with immunotherapy?
No, it's having prior immunotherapy is not an exclusion criteria.
Okay, you were talking about needing to wait that 6 weeks. Can you continue to get immunotherapy while the CAR T cell engineering is being done?
Yes, the trial will allow to continue some treatment while waiting for that to be done. The issue is that when we refer the patients to CAR T is when they start progressing on their current regimen. So for example, somebody is already on immunotherapy and an oral targeted therapy, and we see by scans, the tumors are growing. And this is when we refer them to CAR T. And it takes another 6 to 7 weeks more. So even though if you are remaining on your treatment, we know that is no longer working. And we know that 6 weeks on a treatment that's showing no response, it's a long time. So the idea is that people can remain or be treated with a bridging treatment up to when they get the CAR T back. I think there is a few weeks of washout, but that's not the big problem. The big problem is as once the cancer progresses, even if we remain on that type of treatment, is going to be insufficient for the 6 weeks interval.
So if the cancer is not progressing, then you're not really a candidate for the CAR T cell trial.
Currently, I mean, you can't theoretically, but that's where we are working to revise what we think would be the best option. And it's too early to say a whole lot about that, but in our experience, we believe that is the low volume disease, the ones that are not progressing are the ones who are going to benefit the most. So kind of introducing the CAR-T a little bit earlier and trying to predict when is the best timing. That's where is going to be changed, hopefully in the near future.
Thank you.
That's you.
So kind of using the targeted therapy and the immunotherapy upfront to get as much tumor shrinkage as possible, and then giving the CAR-T while the tumor is still small volume, then don't wait for it to grow again.
My question was, we heard about the ctDNA. I think that's what you're doing. So who's a candidate for that? What does it do? And can we talk a little bit
You
about
want to
that?
talk about that?
I think Dr. Cabanillas is going to talk a bit more about it tomorrow as well. But basically, we're now doing it in all of our anaplastic thyroid cancer patients. And the concept is that, as Dr. Dadu mentioned, they're going to take each patient's tumor and they're going to make a specific test able to recognize your own tumor's DNA in your blood. So the test is really specific to each patient, and they make that in their lab. And then we draw your blood, let's say every 6 weeks or every few months, and try and detect, is there any DNA from your tumor in your blood? And the idea is that when the tumor comes back, it's going to start shedding DNA in the blood before it's big enough for us to see it on imaging. And so we hope that this test would allow us to detect the cancer coming back even before we see it on the imaging. And for ATC, because we know that once the disease starts progressing, it happens quickly. If we're able to detect that recurrence early on, even before it's visible on imaging, then we can act on it then and hopefully be able to treat it better than when it's already visible on imaging.
So would now be a good time to remind Christine that she's going to see us on Monday? She'll see us
Yeah, so
on-
probably Dr. Cabanillas is going to talk to you about it on Monday. So before we were doing it, the way I was doing it is only on new patients to try and just test, is this test accurate for ATC or not, because it has never been studied. Now we know that it works in most of our ATC patients. It's not a perfect test, but it's accurate enough. So now we're going to start using it systematically, even in older patients, not new ones. And so you're going to hear your doctors talking to you about it more. So probably Dr. Cabanillas, knowing her, she's already plans. Sorry. It's called Signatera is the company. Yeah, so it's a ctDNA test, basically, so it measures circulating tumor DNA. But right now, the only commercially available one is Signatera. And you guys got it yesterday, so yeah. I see you guys nodding.
Everybody's getting it.
The scenario you talked about earlier with the nodules or things that are too small kind of sounded like you read my file.
No.
But when you're on Armour thyroid or Synthroid, does that like give false readings for your thyroglobulin? Like it's showing it's lower, but if you're taken off of it, it like goes up right away. So is that like bad sign or?
It's a good sign, actually.
Oh, good.
But
Okay.
yeah, so when we treat papillary or poorly differentiated thyroid cancer, really what we want to do is to suppress that TSH level. So I'm sure that all of you know all about that, but the pituitary gland in the brain secretes a hormone called thyroid stimulating hormone called TSH. And that hormone sends signal to the thyroid gland to make thyroid hormone, which is the free T4, what you see measuring in your blood. Any changes in the free T4 is going to be sensed by the pituitary gland. So for example, if we have too much free T4 in our system, the pituitary gland may think, oh, there is so much, let me shut off. Don't have to do much. I'm just going to decrease the TSH production altogether. If the free T4 in the blood is low, the pituitary may think, oh, what's happening? There is so much less thyroid hormone in the blood. I have to work so much harder now to send that stimulation, and the TSH goes up. And that's just the normal physiology. Now, think about thyroid cancer. Your thyroid is removed. You don't have the thyroid to make thyroid hormone. But the pill that you take, the levothyroxine, the Armour, the tyrosine, whatever you take to replace thyroid hormone, it's what the pituitary gland senses traveling through your blood. So when you take the pill of Synthroid or whatever, you are taking free T4. And if you take too much, it's the same concept. Pituitary gland is going to shut off and TSH is going to go down. If you take too little, then the free T4 circulating in your blood is going to be too low, and the pituitary gland is going to be like working harder, 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 making that TSH in the blood. So that's just normal physiology. But what we know in differentiated and poorly differentiated thyroid cancer is that TSH is a growth factor for thyroid cancerous cells. So if you have high TSHs in the blood, that is going to be a stimuli to the thyroid cancerous cells to produce more thyroglobulin and to grow. So what do we do to prevent tumor growth or prevent thyroglobulin production? We keep the TSH low, right? So how do we keep the TSH low? How do we keep TSH low? Take more thyroid hormone, right? So this is kind of where we are with that. So we want in patients who have papillary thyroid cancer, we know they are thyroglobulin producer, we want that TSH level to be as low as possible. And we give more thyroid hormone. So when that happens, and when the thyroglobulin goes down, where you are on thyroid hormone, that's a good thing because you are suppressing those thyroid hormone. You are suppressing those thyroid cancerous cells to grow. Makes sense? Yeah. No? Yeah. Okay, let me say it again. Yeah.
Be low in what kind of cancers?
Papillary and poorly differentiated.
Thank you.
Add something. Just as a side point, when you're on a drug to redifferentiate the cancer cells, we'll see the thyroglobulin go up, and that's a good thing. So when you have anaplastic thyroid cancer and we have you on a BRAF inhibitor, it's common for the thyroglobulin to go up, and it's not a bad thing. But in papillaries, it's the opposite.
Yeah, some of the chemo drugs that we use can make the cancerous cells more well differentiated and better TG producers. So many times you'll see patients who are on a BRAF inhibitor, the thyroglobulin goes up, but the cancer is responding and is becoming less aggressive. So that's a bit concerning for our patients sometimes, but we did learn a whole lot that this marker is not as great, especially when you are on a BRAF inhibitor.
I'm asking on behalf of my wife. Do you ever see a time where you would give CAR T to somebody who's no evidence of disease? Yeah, like
I never say never anymore. So right now, I think we are going to most likely moving forward with more less disease burden, less progressive type of cancer to get the CAR T. And I don't know where we're going to be in the future. I don't know. If you asked me 10 years ago, would I give immunotherapy for somebody who has no evidence of disease, I would have said no. But now everybody gets it and they're doing excellent. So some sort of adjuvant therapy upfront for at least the first 2 years, even with no evidence of disease, is going to be really the key to the long-term surviving. And what that's going to be is going to change over time for sure. Not sure if the CAR T will be there yet for prime time.
I'm sorry, my voice is raspy from radiation treatment. So my question is, I had the Tempest test done, and it came out with my genomic variant, the main one, ATM, and the PDL1 expression I've not heard hardly anything about that. Is it because it's a rare combination?
Yes, so there, you are saying you had Tempus and there was a ATM and
Yeah.
PD-L1 positivity on the tumor?
PD-L1 expression, yes. It says,
Yeah, so Tempus is a pretty good test in detecting a driver alteration in thyroid cancer. There are other available tests through the hospital systems or other commercially available tests to look for driver mutations, but not all patients will have a driver. So as much as you try to figure out what would be that driver, there will be some patients who we never find it. Many times those patients who have pre-existing Hurtle cell or oncocytic, they may not have the common genetic alterations. And there is still a bucket, the minority of our patients on whom we are still learning what that driver is. So more to come. There is a lot of research being done right now in multiple institutions to look at whole genome sequences and other type of high-level interrogation of the tumors to find that small niche of patients without a driver, what other things might be there to learn from.
could you tell me some of the other tests that you were talking about through the hospital system?
Yeah, so we have our, at MD Anderson, we have our internal genetic test. I know every single major institution has one, MSK, Dana-Farber, all of them have their internal genetic testing. And we used ours quite a bit, but many times I find myself sending to outside other commercial testing such as Tempus and Foundation One or others if we need to interrogate more. There are minor discrepancies. Sometimes you can find a certain rare genetic abnormality in one platform and you didn't find it in other. I have had both happening where our internal test found it, but the outside didn't, and vice versa. So many times when I don't see a driver, I try the best I can to at least test it one more time before committing to a treatment.
Okay.
Is there anybody else on there?
How quickly can BRAF inhibitors stop working? That's a very good question. It depends on the context. For patients with anaplastic thyroid cancer, it works very quickly and very profoundly. However, the duration of response is not excellent. So if you were to just take a BRAF and a MEK inhibitor, you may see a really impressive upfront response. But the duration of that response may be measured for probably less than a year if you just take it alone. And that's why all of the work that has been done, at least for the past 5 years, was to understand what else. Yes, what was really great initially to see that being on a BRAF inhibitor can extend the survival by a year, but that was not enough, right? So the work was to understand how we're going to incorporate different other treatments in addition to the BRAF inhibitor to extend the response. So just by adding the immunotherapy to the BRAF MEK inhibitor, so doing the triplet up front, you can extend the survival even further. What was the survival in our data? 17 months. So if you just use the immunotherapy along with the BRAF inhibitor up front, you are extending it from less than a year to 17 months. And then if you add the neoadjuvant approach, which was using the 3 drugs up front and then going for surgery and then continue the drug, that's extending the survival to 5 years or even more. So a lot of our long-term survivors are actually the ones who have gone through this whole protocol of receiving the triple therapy plus having surgery done. And those are the ones that are responding the longest. So the short answer, just the BRAF inhibitor in combination with MEK alone. I never use it anymore. It was a very good first open eye kind of for us, but that's not the way we should be treating anaplastic thyroid cancer, not alone anymore. It's either in context of adding 1 or 2 more things to it that is showing that survival is extended. So somebody online, Mike, thyroid removed 2014, metastatic 2016, started Lenvima 2019, added Keytruda 2024, still having progression. What's next? Are they doing the CAR-T anywhere near Washington, D.C.? Excellent question. I don't know what type of cancer, Mike. Is this anaplastic thyroid cancer? It seems like a very long 10 years since diagnosis. So for anaplastic thyroid cancer, when it comes to the non-BRAF mutated form, the usual upfront systemic treatments are also combination of immunotherapy with the targeted therapy, and most commonly the lenvatinib plus Keytruda combination is our to-go type of approach. It seems like for Mike, he has been on Lenvima alone for 5 years prior to adding Keytruda. So I would guess that probably he may have had just papillary initially, and then Keytruda was added later on. There was a clinical study, actually was just published this year, was done through the ITOC group, and what they were looking for was adding Keytruda at the time of progression to Lenvima versus treating with Keytruda plus Lenvima upfront, and this was for differentiated thyroid cancer, not anaplastic. And it seemed like in differentiated thyroid cancer, it did work for another 8 to 9 months after you just added to the Lenvima at the time of progression. In anaplastic thyroid cancer, there was a study looking at the Lenvima alone, and the US study actually was closed very early because didn't show any efficacy when it was used as a single agent. There was a study in Japan showing that the Lenvima work alone, but we did not replicate that in US, and it was actually a pretty short-lived study. And then when we added Lenvima, Keytruda to the Lenvima upfront, the results were remarkably different. I have a couple of patients, and I see one is online right now, but we started adding this about 4 to 5 years ago, and it's impressive how long some of our patients respond to the combination. There is a clinical trial ongoing right now with Lenvima and Keytruda upfront, and hopefully we'll have some answers in the next 1 year or so. But it's a mix. Most of my patients do well with the combo upfront. After progression on Lenvima and Keytruda is becoming a little bit more difficult, and it all depends on really what that genetic driver is. And once the progression has occurred to Lenvima Keytruda, then the options are primarily clinical trials with the CAR-T, with the newer pan-RAF inhibitors if there is a RAS mutation, or trying to find the fusion. I have patients who we didn't find the fusion initially, treated with Lenvima and Keytruda upfront, and then the time of later on we identified the fusion, and then we were able to treat with the fusion-directed therapy. So that field there, it's a little bit behind, and hopefully that's the work to be done in the next few years. What do we do for the non-BRAF? Lot of efforts are now being done to try to use surgery and radiation along with the Lenvima and Keytruda. And so a lot of our patients now get some sort of low degree of radiation along with Lenvima, Keytruda, and then we try to take them to surgery if we can later on. Trying to replicating in a way what we've done for the BRAF mutated tumors, where we're going back to the drawing board and taking the tumors out, maybe helping as well. So jumping ahead of the game where actually the tumor is responding and responding very well, maybe that's the time where you should do a more consolidative type of treatment approach rather than waiting for it to progress. So if you're able to shrink it and shrinking to a low level, maybe this is the time you should be acting with something else rather than keep watching and waiting for that progression to occur.
I want to ask real quick on that combination of the Keytruda and Lenvima or ATC, did those patients of yours you saw, did they have mets, where it moved to the lung or moved to somewhere else?
Yes, it's a combination. For the clinical trial, it's not required for them to have distant meds, but I would say from the top of my head, I think the majority do have distant meds. Mm-hmm. That's all great questions, everyone. It was so nice to meet you all in person, put some name to some faces. And I really hope that we continue to work together to make this anaplastic thyroid cancer history. So thank you all for your attention. It's always so great to hearing from all of you and learning from you. And thank you for all of the hard work that you are doing. Because I know, yeah, you are doing the hard work, trust me, being and going through that. We are here to guide you, but you are doing the heavy lifting. I hope you have a great rest of the conference. Bye, you all.